I think we can go ahead and get started. So I'm Professor Laser. I'm excited to have recently joined the faculty at Cleveland Marshall, where I focus on intellectual property and innovation law. Today's panel is going to focus on innovation in the pandemic. Advances in pharmaceuticals and medical devices cannot always happen without the incentives to innovate provided by things like intellectual property protection and the trust and safety that we have in our medical products and drugs that are protected by agency regulations. And yet all of these intellectual property and regulations can create thickets or slow the development of novel technology in emergency situations, some people might urge. Today, we're going to discuss the lessons that the pandemic can teach us about the right balance between safe and fast innovation and about regulation versus agility. So to start with, we have a wonderful group of panelists here today. If each person could introduce themselves briefly, I'll start with Dr. Salata.
Thanks, Krista. So I'm a professor at Case Western Reserve University. I'm also the department chair of the Department of Medicine, and I'm also trained as an infectious disease person. Has been very involved in the whole COVID situation, which we're going to focus on today.
Great, and I'll also add that you also have significant experience from the HIV crisis as well, right?
Yes.
All right, would Professor Kumar introduce yourself?
Hi, I'm Professor Sapna Kumar from the University of Houston Law Center. I'm also co-director of our intellectual property program, and I focus on US and international law issues with regard to patents.
Great. Professor Contreras?
Great, hi. I'm Jorge Contreras. I'm a law professor at the University of Utah, and I also have an adjunct appointment in the Department of Human Genetics in the School of Medicine. I teach and research in intellectual property law and have been involved in a group called the Open COVID Pledge, which we'll talk about later today.
Thank you very much. All right, so I'll jump right in for some questions that I think are best answered by Dr. Salata, but others are welcome to jump in. Dr. Salata, you have experience as a clinician getting treatments for infectious disease through the FDA process. Can you tell us a little bit more about the FDA approval process for the vaccines during the current coronavirus pandemic and the relative pace of some of the studies that we've seen to get approval of these vaccines fairly quickly?
In this unprecedented time, it's been extraordinary to see how rapidly we've been able to move to the point of having therapeutics, that is treatments, and also most importantly, the vaccines. The federal government named this process Operation Warp Speed. I never liked that term because that suggests that we're moving too rapidly or cutting corners. And that was not the case at all. As an example, I was the principal investigator of the Pfizer vaccine trial at our institution, one of 120 around the world. And we started this process probably in May. We enrolled our first patient in August and completed the enrollment of about 180 individuals by the end of October. We had daily, sometimes twice daily, calls with our colleagues at Pfizer. And this was one of the most scrutinized clinical trials I've ever done, and I've been doing this for 30 years. In that regard, everything was very carefully managed, and I think that was important for the success in the end. I call this moving at the speed of science, not warp speed. And I think in that regard, we followed our leads, and this was important. When enough information was gathered, and the primary endpoint here to look at vaccine efficacy was not only the safety issues, but also how well it was in effectively preventing COVID infection. And it was compared to placebo. That is, we gave just salt water as the alternative in a randomized, controlled, blinded study. And it was 95% effective when you looked at this. This is similar to what Moderna reported at 94+%. It's different from some of the other vaccines, including Johnson & Johnson, which we could come back to later. But I think we are very proud as an organization and being involved in such studies. As well, we were the first site in the country to start studying the antiviral drug called remdesivir. And this is the only one that's fully FDA approved right now. And in that regard, it is being used globally as part of the standard of care here for COVID infection. Related to the FDA in the end, this was granted, Pfizer, Moderna, now Johnson & Johnson, what is called early emergency use authorization, excuse me. And that really occurred after the materials were submitted. There were expert panelists that are independent of the FDA looking at this data, and then they made their decision. All three of them have received this. This is not full FDA approval yet. I know Pfizer is going to submit that additional material to the FDA soon for that purpose, but everything looks pretty good. And the last thing I'll say right now is that the whole country of Israel, which has been ahead of everybody else around the world in terms of vaccinating their population, did a real world experience of the efficacy of the Pfizer vaccine. That was the only one they used there. And the predominant circulating virus in Israel is the UK variant, which is more contagious and probably also is associated with more severe disease and death. And their real life experience was that it was 94% effective, similar to the studies that we were involved with. So that gives us, I think, further reassurance about how this has moved along.
That's great. I love the term, the moving at the speed of science. It's, you know, we often wonder how much are we taking away from safety when we move with a certain speed? But it sounds like in this process that we didn't really have that kind of compromise to safety.
And yes, there are side effects that have occurred with all of these vaccines. That's been well reviewed in the literature and by anybody that's receiving the vaccine. But for the most part, we've seen no patients die in a cause and effect relationship to the vaccine. And these side effects that occur are very much temporary. And by 24 to 48 hours, they're gone. Some people have more severe reactions than others. That's par for the course, especially in those individuals getting vaccinated after having COVID before. And there's a lot of debate right now as to whether or not we should only be using one dose because they have such a vigorous immune response, as manifested in part by their side effect profile. So that's where we're at right now. But we did not sacrifice anything in terms of safety. Now, lastly, we are following people from the vaccine trials out to 2 years after their second dose. And this is to look for late occurring safety signals and also to look at the durability of the immune response. You may know that Pfizer and Moderna now are starting booster doses and or next generation doses to address right now the variants that are circulating around the world, including in the United States.
That's very helpful. One last question on this. You've worked on the HIV pandemic as well. Do you see any parallels between how we've responded to the coronavirus versus the HIV pandemic and why that process might be the same or different?
Well, in some ways, it's the same with respect to the fear that was among our healthcare workers, initially in caring for HIV-infected individuals, and later with coronavirus. So that's similar. But again, the speed of the science here has been greatly accelerated by coronavirus. Within 2 weeks of its first being detected, we had the full genetic sequence or makeup of this virus available to us. That really led to the development not only of therapeutic agents, that is drugs to treat it, but also the vaccine initiatives. So very early in March of 2020, there were studies by multiple scientific groups on the development of these vaccines, and it led us to this point. In 9 months, to imagine having a vaccine is just extraordinary. In most other vaccine trials, it takes years. And also that was the case with HIV. By the time we identified this virus and developed diagnostic tests and treatments, it wasn't until the mid-90s when this was first discovered, that is HIV, in 1979, 1980, that we had very potent medications available for treatment. So that really is a much more condensed timeline in terms of the COVID situation.
Thanks. And I guess one more follow-up. Do you think that this virus has taught us lessons about how fast we can innovate in a pandemic that we can now bring to future diseases?
Absolutely, it's mind-boggling. But one example let me use is the development of the messenger RNA technology for delivery of both Moderna and Pfizer vaccines. This was actually in place for over a decade before we arrived at this as a strategy. But the idea that we can use this for other vaccines, even new generation COVID vaccines and whatnot, is just astounding. This was first being developed, by the way, in Germany for the potential application of drugs to use in cancer. So that's another area. So I think there's going to be tremendous spillover into many other areas, just in part related to that technology alone, but how rapidly we were able to mobilize, and actually the cooperation, which was extraordinary between not only folks in this country, but around the world to get this done.
Thank you. I'm going to move on to some questions for Professor Kumar. Before we do that, I'd like to note that for those seeking CLE credit, the code to use on your form is innovate. The code again is innovate. All right, so Professor Kumar, intellectual property can also be another hurdle to expedient deployment of drugs and treatments in emergencies. And you wrote a paper recently on patenting in the pandemic. Can you tell us a little bit about that work?
Sure. So patents are really a double-edged sword. On one hand, we need them to spur innovation. And that includes during epidemics, pandemics, or the like. We need drug manufacturers, we need pharmaceutical industry to have an incentive to produce new drugs to treat the pandemic. On the other hand, patents can lead to drug shortages. And so the question is, how do you mitigate those two things? How do you have sufficient incentives while being able to address situations when there aren't enough drugs? And we've seen it play out in two different ways. Just to give a couple of examples, a good example is with Johnson & Johnson and Merck cooperating. There wasn't enough production facilities for the Johnson & Johnson vaccine. And while the Biden administration kind of helped nudge the agreement along, ultimately the two companies cooperated with each other, with Johnson & Johnson sharing its knowledge, its know-how and technology, and Merck agreeing to produce the drug. So that's an example of a good voluntary outcome. But we've seen bad outcomes as well. And I think remdesivir is the best example of this, where Gilead Sciences did out-license to some manufacturers in India, in Pakistan, and elsewhere, but they restricted it to only certain countries. So while we had a shortage in the US last summer of remdesivir, countries in Asia and elsewhere had plenty. And that included in Bangladesh, where they weren't subject to the patent for remdesivir, independently created it in a period of just months, and then started exporting it to 19 other countries. So in my paper, what I talk about is we need to have more mechanisms to deal with those kinds of situations where you have a life-saving drug, but you have a company that's not fully taking advantage of producing it at the level that it's needed.
Thanks. So what mechanisms do you think that the US government could use or that other governments can use to make sure that we're having access to as many vaccines and drugs as we need during a pandemic or another emergency situation?
Sure. So under existing law, we have mechanisms for the government to produce patented goods without patent holder permission or to enter into a contract with a third party to produce drugs or other patented goods on behalf of the US government. And this is generally referred to as what's called compulsory licensing. And right now, under US law, it's extremely difficult for a third-party manufacturer to obtain a compulsory license, even if it has the production capacity to help out. So one thing we need to do is make that process easier, where if there's a shortage, a court should be able to just authorize the compulsory license. And a second issue is where the government is funding the production of the drugs. In those cases, I think there should be a requirement that in the event of a drug shortage, that the patent holder, the pharmaceutical company, should be required to outlicense the technology to another company, like what we saw voluntarily happen between Johnson & Johnson and Merck.
Just to follow up on that, you mentioned compulsory licensing. What are some of the reasons why policymakers perhaps wouldn't want to expand compulsory licensing, or why is there pushback against compulsory licensing in some circumstances?
Sure, there's always part of this is about striking the right balance. You need to have enough incentives that when the next pandemic rolls around, there will be companies that are willing to invest the money and put in the time and effort to get new drugs. On the other hand, you want to have some kind of a balance, and that includes not just shortages, but also for cases involving countries that can't afford a drug, countries that don't have access to it. You need a mechanism for them to be able to get the drug as well. And as you can guess, there's a lot of money that rides on this. And so on one hand, you have a very influential pharmaceutical lobby that basically wants patents to be as strong as possible and doesn't want any carve-outs in it. And on the other hand, you have groups like Doctors Without Borders, you have humanitarian groups that are trying to gain greater access to drugs for people who don't have them. And so the question is, how do we best, walk that, that line between spurring innovation and not excluding access to certain groups?
It's an interesting point. Something we discussed in my innovation law class a few weeks ago was, how do we provide the incentives for pharmaceutical companies to try to support compulsory licensing? And one of the concerns I think that many pharmaceutical companies have is over gray market goods. If they offer lower pricing to a third world country, is that going to result in those kind of drugs coming into the US at low prices and not being able to fully recoup the value of that? So, perhaps having more protections against gray market goods could help to support the policy goals of compulsory licensing.
And to be clear, with drugs, you can't really have gray market drugs because of how the FDA regulations work. It's only going to be the licensed, the patent holder basically, who's going to be able to authorize the drugs. You can't just import in another source of drugs. At least I'm not an FDA expert, but my understanding is you can't bring in gray market drugs.
Yeah, they won't be labeled properly for sale in the US.
That's exactly.
So it doesn't stop people from doing so illegally, I suppose.
Fair enough.
Great. Well, thanks for that. I'll move on to some questions for Professor Contreras. Unless others have commentary on any of these questions of getting these drugs compulsory licenses or otherwise getting access to patented drugs. Any other comments on those from the other panelists? No. All right. Professor Contreras, so you mentioned earlier that you were involved in what's called the COVID-19 pledge. And there are ways that the patent system can sometimes be changed, but businesses can also take a lead on their own to address various hurdles. Can you tell us a little bit more about what the COVID-19 pledge is and what it's been used for during the pandemic?
Sure, sure, absolutely. So in thinking about the technologies and the products that are necessary to respond to a pandemic like this, there's a wide range of products and technologies beyond the vaccines and therapies that we've been talking about. If you recall, a year ago in March 2020, when the pandemic first appeared in a big way on the radar screen of most people in the United States, there was a spate of news stories about how patents were being used to disrupt or to limit the supply of things like hospital ventilators, respirators, other PPE equipment, diagnostic kits, and so forth. The conversation, of course, about vaccines and therapies was there and was quite prominent, but this other conversation was going on as well, because there's a whole range of technologies necessary to respond to a pandemic of this scope. And so as a result of that, I and a number of other academics, legal and scientific and engineering types got together to try to figure out a way that we could facilitate firms and institutions that held intellectual property rights in these areas to make them available in the response to COVID-19. There are clearly mechanisms, as Professor Kumar mentioned, such as compulsory licensing, also efforts through the United Nations to pool intellectual property in these areas. And those efforts are, of course, very important and largely focused on the vaccine and therapeutic world, but not so much in these other areas where, just taken all together, they probably represent 90% of the intellectual property that is relevant to the pandemic. And so we put together a framework, sort of a set of legal documents that could be used by entities to contribute their IP without charge to the response to COVID-19, only during the duration of the pandemic and for a year after that, and only for use within the field of responding to the pandemic.
Thank you. So I noticed that there were a number of different technology companies that signed onto the pledge, such as Intel. Why do you think it is that more biopharmaceutical companies and therapeutics makers had not signed the pledge?
Yeah, we observed some very interesting trends when the pledge was rolled out last April, and it was exactly as you said. We got a variety of entities that came forward and made pledges. The vast majority of the rights that were pledged were in areas like digital innovation, software, but also in medical devices and products, protective equipment, and so forth. Relatively little in the area of biopharmaceuticals. And I think they're just different markets, very different markets. In the biopharmaceutical area, the vaccine that's produced, the therapy that's produced is a major source of revenue for a particular company, and opening intellectual property to competitors might be viewed as counterproductive for an entity. Some of these entities, like Moderna, have pledged their intellectual property in this area, but there are speculation about reasons that they did that, which is not entirely altruistic. Nevertheless, the financial equation is very different. For the technology sector, those companies don't rely on patents in this area as principal revenue sources. They primarily sell products. And so these types of companies that aren't going to make a business of monetizing their patents or trying to block competitors were able to take this step for a number of reasons. I mean, both out of a sense of corporate social responsibility, which generates goodwill, both externally with the public, with government regulators, but also internally with employees and internal stakeholders. So there's that plus. But they also open up technologies for use in ways that might not have been contemplated. So for example, contact tracing is an example of a technology that's become important for modeling disease spread and for attempting to constrain disease spread. Much of the intellectual property around the logic and the tracing algorithms and disease modeling and predictive algorithms is held by large companies that made these pledges. IBM, Fujitsu, Intel, Microsoft, Facebook, Amazon, all of these companies pledged basically all of their patents in the fight against COVID-19, which creates in these areas like disease modeling, contact tracing, even to some degree disease discovery. It creates what we like to think of as an open innovation field where small entities, small companies, individuals can experiment, create apps and whatnot without the threat of patent litigation lurking in the background.
And just to clarify for those who aren't very familiar with the pledge, does the pledge provide only for non-commercial use, or does it permit commercial use if it's for the purposes of helping against the pandemic?
Yeah, that was a really interesting design choice that we had to make. A number of pledges like this are limited to non-commercial use, but we decided that we would not create that restriction because the main point of this was to get products into the marketplace, into the supply chain, and companies who make products have to sell them. They can't just give them away in most cases. And so to respond to the pandemic, we thought that allowing commercial use was important. So we don't have any restrictions on the downstream uses of the pledged IP. It can be for commercial use. We don't restrict prices. There are separate price gouging laws in effect in many countries that are in theory in place to handle that. But we did want to give the users of this technology the maximum flexibility to use the pledged technology.
Great, thanks. And what are some examples? You mentioned a couple of technologies along the way, but what are some of the technologies and treatments that you've seen benefit the most from the licenses granted under the COVID pledge?
Yeah, so first I'll give you a caveat, which is it's difficult to trace this because we don't ask licensees or users to identify themselves or to register in some way. We could have done that in some other pledges, such as some pledges offered by university licensors do have those types of registration and record keeping requirements, and we thought that would just be a disincentive to signing up. So the caveat that it's difficult to track these things, if you lump together the Open COVID pledge plus other pledges made by companies in the field unilaterally, a great example is hospital ventilators. Right, these are very important for treating patients who present with symptoms of COVID-19. And we all heard the horrific stories of incredible shortages in hospitals, both in the United States and also around the world, of this equipment, people having to share ventilators and so forth. One of the problems was the inability to create parts for ventilators. They do wear out relatively rapidly, and you need more parts, and the supply could not keep up. And so you start to have individuals creating parts using 3D printers in their garages. These, in theory, infringe intellectual property rights, and there was some press about that early on in the pandemic. Large ventilator manufacturers like Medtronic and Smiths Group pledged that they wouldn't assert IP rights against people who were making ventilator parts to go in their ventilators. As part of the Open COVID pledge, there is an open source ventilator consortium called the OVSI, the Open Ventilator Systems Initiative out of the UK, which makes has made ventilator designs primarily for portable ventilators for use in the developing world, free and publicly available with no intellectual property. And that's a great story because this is a very important piece of equipment that is in dire need in responding to a pandemic like this. Masks and respirators is another good example. Two national laboratories, Sandia and NASA JPL, are part of the Open COVID Pledge, and they developed respirators and masks that could be produced at home, N95 respirators that could be produced using 3D printers and easily obtainable materials, and made all of this information and intellectual property publicly available. So, there are some good examples, definitely not as high profile as the vaccine space, but we feel this is, a gap in the in the innovation and intellectual property world that's not really being addressed by governments with compulsory licensing or the World Health Organization, but is still important in the COVID response.
Makes sense. And it sounds like there may be a lot more that can be possible with this sort of industry or private negotiation than could be possible from as you said, government compulsory licensing or forcing industry participants to engage in a certain way with the market. What other lessons do you think that we can draw from the Open COVID Pledge and its successes on the possibility for industry cooperation on intellectual property issues and for future emergencies?
Yeah, well, I mean, of course. So since a number of us were academics who, who created this, we were thinking sort of about the theoretical implications here and how this could be translated to other disasters, other public health crises, and the big one that's looming ahead of all of us, which is climate change, global climate instability, and whether intellectual property sharing frameworks like this could be helpful in addressing those future situations. And I think the answer is yes. I think there is a willingness in the corporate and institutional world to make intellectual property available, especially if it's not being used in somebody's primary business, without giving it away or contributing it to the public domain. It's kind of a happy middle ground where they can do some good without seriously damaging, their own financial prospects. And I think that I've already been in discussions with a number of companies about extending this type of framework to other areas, and I think it looks very promising.
Thank you. So I guess one last question on this before we move on to the general questions for everyone. Is there a fear at all that if there is a lot of public pressure to make intellectual property available in emergencies, does that undermine the incentive to innovate on, breakthrough medications or breakthrough medical innovations that could help in an emergency, if that's the primary source of revenue that perhaps a company has?
Yeah, so this is sort of, a subpart under the compulsory licensing question, right? I mean, compulsory licensing is often opposed for that reason. With a voluntary system, I think the risk is much less. Entities create intellectual property for many, many reasons, including just as side results of main development projects that they are putting together. And so I don't think that a voluntary system impairs the innovation landscape at all. In fact, the voluntary system has many benefits in terms of innovation and creating an open innovation landscape. And there's sort of a broader story and theory around these types of patent pledges. If you remember, back in 2014, Tesla Motors, Elon Musk pledged that Tesla would not assert its patents against anyone who was using them in the electrical vehicle space. That seems counterproductive. It seems like self-inflicted harm, but it's really not, right? The goal for Tesla was to increase the broad infrastructure throughout the country for electrical vehicles, something that one company alone couldn't do. And if you view your competitor not as other electric vehicle makers, but as the traditional gasoline-powered automotive industry, then you want as many innovators as possible outside of your company to join in. And so I think with, again, examples like contact tracing and so forth, Microsoft or Facebook might not have been the one to make the best contact tracing app that would be adopted all over the world. That's probably going to emerge from local, players in different countries around the world, maybe even individuals or healthcare providers but they're, innovation helps the whole industry when we're continuing to use, products that link with these outside innovations.
Thank you. I see Professor Kumar has some thoughts on this as well. Go ahead.
Yeah, I just wanted to say, ideally, we want to get pharmaceutical companies, patent holders of life-saving technology and the like to act in a voluntary fashion to do the right thing. If there's any way to spur that, we should be, or to foster that, we should be doing that. I just think we need both carrots and sticks. I think that, we need to try to encourage them to do the right thing as much as we can. And if that doesn't work, if they won't, not only will they, not produce enough, but they won't share the know-how that they have with others, they won't share the technology with others, then I think we need to have backup plans for those situations.
Fair point. All right, so if anybody in the audience has questions, please submit it through the Q&A. We don't have any questions in there yet, so I'll jump to some that I have for all of the panelists. But anyone who has questions, please type it into the Q&A. All right, so there's some interesting news about India and some other countries petitioning the WTO to suspend certain IP rights during the pandemic. Do the panelists have any view on whether that's necessary and what the potential repercussions could be if something like that were to come into play?
Yeah, I'm happy to go first on this.
Go ahead.
This is super interesting. So countries like India are trying to make basically the argument that, look, we've got a pandemic, there's lives on the line, we should be able to override, all the requirements that we're currently subject to under the TRIPS agreement with regard to patent rights for these particular technologies and kind of be freed from these restrictions. And I see a couple of issues with this. One, we need to have drug companies be, incentivized for the next pandemic. So I have the fear that, first of all, if we found a way to suddenly say, okay, we're putting aside all patent rights on all drugs, if there was a mechanism to do that, then I would be really concerned the next time we have a pandemic, who's going to invest the money to, bring us the vaccines that we need, to bring us the treatments that we need, given that that could happen. Second, there's a feasibility problem as well in terms of whether the WTO can actually whether they can actually do anything. And I know George is going to want to jump in on this, but I'll just briefly say this. The US violates the TRIPS agreement all the time with very little repercussion because, we can just pay fees, we can just sort of ignore them. So, I mean, we punish other countries for exercising compulsory licensing, even though what they're doing complies with TRIPS, by giving, basically subjecting them to trade sanctions. So I'm not really sure what the WTO can actually do in this situation, and I'll let George expand on that further.
Yeah, no, I agree, and I think Dr. Kumar has basically said it. The WTO cannot suspend IP rights. Only national governments can affect IP rights in their own countries. Countries who want to do that are already authorized to do that under the Doha Declaration of the TRIPS agreement, which has been in place for 20 years now, and they've done it in the past. India has issued compulsory licenses. Thailand, South Africa, Brazil, many countries have already done this. I mean, the request of the WTO, even though the press has reported it in a much more grandiose way, is really that the WTO should not enforce sanctions against countries that have done this. But, WTO or not, there are ways that countries can impose sanctions unilaterally, and the United States does that all the time, with or without the WTO. And so I think it's a nice gesture that's sought, but I honestly, from a legal international law standpoint, don't think that it really is particularly effective in any real way.
Thank you.
Harkening back to the HIV situation. This always raises issues about creation of generic drugs at a much lower cost. And the only way to be able to treat people, for instance, with HIV on a yearly basis, which in the United States may be as much as $20,000 to $25,000 per, is to have available generic drugs. And I think there have been issues about oversight, quality, et cetera. So that all has to be taken into consideration, not only in India, but other countries, some of which were mentioned. So I think it's always a balance here, aside from the international laws that are being spoken about in terms of what's right for patients and what's right globally as well.
Thank you. So we have a question from the audience that comes off of some of this as well. Many developing countries are facing diseases where there are insufficient financial incentives for major drug companies to develop the kind of breakthrough in science that we've seen in the COVID-19 pandemic and in other types of diseases that affect the wealthier, more developed world. What can we do to address the underfunding of neglected diseases, and how can we help to change some of the economic incentives to ensure that neglected diseases are getting the incentives for breakthrough medicine?
Maybe I could start because I do work in Africa in the HIV sphere, but they're facing major issues at present related to COVID on top of all those other problems like HIV, tuberculosis, malaria, et cetera. And I think, again, some of this has typically sat with the World Fund and other organizations like that. And also there is funding through the Gates Foundation, the World Health Organization, and other things to try to balance exactly what you're asking about. But it's very difficult and challenging. And right now, they can barely stay up with, at least in sub-Saharan Africa, with enough testing, which we faced as well, right, in the US. But it's even more dramatic there. And people are dying left and right from COVID. But they have the other things to contend with as well. So we have to put this into perspective, develop priorities as we move forward from a global health perspective, that's for sure.
Do others have thoughts on other ways to increase incentives for these less attended to diseases?
Yeah, I wanted to just say that we, for the countries that have the resources, we need to take a much longer term perspective with regard to funding for this kind of research. I know that Professor Anna Santos-Rutschman's written about this, that just these temporary infusions of cash with regard to, oh, here's a pandemic, let's just pour some money into it. That's not a really effective way in terms of having long-term research get conducted. There needs to be a steady stream of funding. And part of that means that, those of us in countries like the US need to realize that public health is a global thing. If there's if there's an epidemic going on somewhere that seems far away, well, that could impact us. So we need to, take those outbreaks seriously before they reach our borders.
And an example of that, it's very important that you brought that up, is Ebola, for instance, when it occurred in Western Africa and large urban areas for the first time, and many of those cases did come to the US as well. So we have to be on guard at all times. And the other message here for everybody to realize is that we're going to see pandemics in the future. That was alluded to. This continues to haunt us with air travel and the closeness of our populations. There's no doubt that this will happen again. And I have to say that I've been so focused on this because we weren't prepared for this outbreak at all. And if we do nothing to, as suggested, improve our infrastructure for dealing with this in the future, we're going to continue to face problems and challenges ahead.
Yeah, but it's definitely a political decision, right? It's not a market decision. The pharmaceutical industry around the world is market driven by and large, and the market can't solve that particular problem. That's a political problem. I mean, the fortunate thing is that most basic research is done in the academic sector in this country anyway, and the US NIH has this $40 billion of extramural funding, is the biggest biomedical research funder in the world. And academic researchers follow the money. I mean, it's obvious what they're going to research. There is so much research being done on cancer, even extremely rare cancers, because the NCI is an enormous source of funding, and that's a good thing. You know, we do want to eradicate cancer, but there's very little funding in the United States for rare and tropical diseases, and that could change. And I agree with Dr. Salata. This is, and Kumar said, it's a global problem. Like, thank God COVID-19 wasn't Ebola, you know, with double-digit fatality rates. It easily could have been. We've dodged that bullet, you know, just through sheer luck in many cases. But if the government funded these types of research programs more, we can't rely entirely on philanthropic organizations like Bill and Melinda Gates, which have been very proactive, especially with respect to malaria and other tropical diseases. But you know, that's not enough. Governments are the bigger source of funding.
And just as another point, the NIH is very eager to fund international research. We have as much to learn from what's going on in other countries, like the third world, developing areas of the world, as we do here. So that's been a major theme pushed by the NIH, among other funders. But since you mentioned, they're the major biomedical funding process in the United States. The same thing is happening in the UK and in European countries too. So I think we've woken up a bit to this issue, that we're not isolated anymore. And we have to improve that process even more so. Is it where it should be? No. But I think that's starting to happen.
Yeah. Thank you for those answers. I think it's interesting when you try to say, what can the market do and what can governments do?
Yep.
Sometimes there may be mechanisms to try to change rules and laws and practices to further incentivize the market. For example, Health Impact Fund is one way that this could be addressed, where countries would put patents into a fund, sell them at cost globally, and then get a share of the fund in exchange according to use. So that, for example, if an Ebola drug is developed in the US and distributed in Africa, the US would get funds for that. That could help to incentivize private market participation in those more diseases in less developed countries. One other question from the chat, I think that ties into this, is what are some of the factors that led the COVID-19 pandemic to be one of those pandemics where we did see a rapid response, huge investment of resources, and extremely fast deployment?
I just wanted to mention the Defense Production Act, because that's been one big help in terms of how do we cut red tape in terms of getting the vaccine, the manufacturers, the tools that they need to produce enough of these drugs. And I don't think it was deployed nearly enough last year. I think we're seeing it get used a lot more now under the Biden administration.
All right, well, we're running near the end. We have one more question that I think might be a good way to wrap up. We need to take lessons away from this pandemic. And one of them is, what do we do to prevent the next one and make sure that we have everything in place well beforehand and are not rushing at that time? How do we get policymakers to focus on preventative investment in future pandemics?
I think it starts at the top. And under the previous administration, this was not a priority in my view. And with the brand new CDC director, a friend of mine actually, this has become a major issue for her. That is, our infrastructure in public health is very poor. And it's been further challenged by the fact that over 199 individuals in the public health sector have either quit or been fired or have just given us up. And I think that's a major lesson for us, because undoubtedly, in my view, pandemics will occur again. The last one was in 2009 with the influenza pandemic, not nearly as severe as what we're seeing now. But could it be, as was mentioned, we see something like on the scale of Ebola occur? This really will mandate that we change our whole perspective on this. So I think better prepared for one, having the right people in place, investing in that, in my view, is very important because we can't be caught unprepared as we were this time.
Thank you. Professor Kumar, Professor Contreras, do you have any final thoughts on that?
I'll just very quickly say, I mean, I think we in this country were lulled into a false sense of security because previous epidemic scale outbreaks like SARS and H5N1 and H1N1 were not that serious in terms of human fatality or economic impact in this country, and so weren't viewed as a huge political priority. I mean, this really is driving the point home, and I think any sensible administration will, ramp up the funding to CDC. What was done to CDC funding over the last few years is atrocious and really, should be reversed and completely changed. And I think this is the lesson that we'll be able to point back to for a generation as to why we need pandemic preparedness in this country.
I'll just add one last thought, which is this goes beyond innovation policy at the end of the day. We need, people to have health insurance. We need paid sick leave so that people aren't showing up with symptoms of COVID-19 because otherwise they don't get paid that day. Like, we need to address some of these broader, infrastructure issues, in addition to just thinking about IP policy.
Well, thank you all for your input today, and I really enjoyed the conversation that we've had, so I appreciate you all coming.
Thank
Thank you
you
so much.
Thank you so much.